on behalf of MIDAS Medical Foundation and MIDAS Institute of Gastroenterology. It's a 116th clinical meeting, and the cases as usual would be definitely challenging, and I'm sure that would be useful for practitioners to deal with day-to-day problems. May I welcome chairpersons for today's meeting. Dr. Kanhaiya Chandak, please join on the chair. Dr. Prashant Bhote informs me that he could not join because of some family issue. So I will request Abhay Kumar Sinha to please join there. Dr. Ritvik Lohia is a new gastroenterologist in the city of Nagpur, who joined AIIMS Nagpur. So we'll have his expert opinion. He's a DM from gastroenterology from the prestigious CMC Vellore and spent 2 years there. And now he is available in Nagpur. So Dr. Ritvik. And Dr. Abhiram Paranjpe informs me that he will be joining little late. And then we have online chairpersons, Dr. Kailash Mishra from Jabalpur, gastroenterologist, senior gastroenterologist, Dr. Arun Iyer, gastroenterologist at Raipur, and Dr. Ankit Dalal, who is a gastroenterologist from Mumbai. So he is working with Dr. Maidev. So we'll have 7 persons as chairpersons. So with this short introduction, I'll request the chairpersons to start proceedings.
Good evening. At the outset, on behalf of chairperson, I thank Dr. Mukhewar sir, Dr. Saurabh and team MIDAS for giving us this opportunity to chair the session. I also congratulate Mukhewar sir, Saurabh and team MIDAS for conducting successfully 115 meetings, and today we are all here to witness 116th meeting of MIDAS. So today we'll start with the first case, that is unusual case of gastric outlet obstruction, to be presented by Dr. Shrikant Mukhewar. Shrikant Mukhewar.
Well, this was one of the most challenging patients which we had, presented to us a very unusual cause of gastric outlet obstruction. Story of a young girl, 26 years old, who was seen first time in MIDAS on 16th of January. She had history of abdominal pain for 4 months. It was moderate to severe, increase after food and associated with large vomiting, not bilious, there was no blood. She had constipation, hard stool straining, but there was no blood loss. There was a weight loss of 4 kg in 4 months. Her hematological investigations revealed that her hemoglobin was normal, the counts, platelet, liver, kidney function, sodium, potassium, everything was normal. Eosinophils were 2%. We got her CT done. As you can see the CT, because she had an ultrasound, you see the dilated stomach, the dilated first and second part, and then there was a narrowing from the third part. Have you noticed? Or should I play it again? Yeah. In fact, this is all dilated, this is dilated, and this is getting narrowed here. So, there was a third part obstruction. There were small subcentric lymph nodes, dilated mesenteric vessels. So the impression was that the patient has gastric outlet obstruction. We had to find unusual site for gastric outlet obstruction. So what are the possibilities? Anyone wants to suggest in a young patient what are all the possibilities one would consider third part of duodenum obstruction? Tuberculosis, good. Anything else? Well, good. First possibility was SMA syndrome. Sometimes in patients with Zollinger-Ellison syndrome, you can have ectopic ulcers and can cause severe disease, and that can cause tuberculosis. Of course, when you have a tuberculosis, you have to discuss Crohn's. Eosinophilic. Eosinophilic by and large is associated with thickening of the bowel, but strictures are not very common with eosinophilic enteritis. Vasculitis, ischemic etiology leading to obstruction has to be thought of. Extrinsic compression, you never know. Pancreatic mass and other things can cause third part of obstruction. Malignancy and lymphoma. These are all the possibilities which we thought. So obviously the first investigation after CT was to go ahead with upper GI endoscopy. For want of time, I am just going to show you the lesion itself. So we went into the stomach. There was evidence of dilated stomach with stasis of food material. As you can see here, there were ulcerations. As you can see in ulcers of peptic ulcer, similar ulcers were there. The mucosal fold were edematous. So the biopsies were obtained. In fact, it took about 20 to 25 minutes for us to clean the stomach, go into the... Because of the critical narrowing, we also thought that let's put the NJ tube beyond. So we put an NJ tube. And the first, as you can see while withdrawal, the first and the second part of duodenum. And this is the stomach, the fundus. Still the fluid residue was there. So this was the first endoscopy. The biopsy from the duodenum showed ulceration, lamina propria lymphoplasmacytic, eosinophilic. So probably some non-specific etiology. We couldn't come to any conclusion with this biopsy. May I request Abhiram to please join. So within a span of 4 days, on 27th, 4 or 8 days, we got her repeat endoscopy done because we were sure that there is something which we are missing. And normally when there is no clinical and histological correlation, it's our practice to get repeat biopsy without giving cost to the patient. So this was a tube which you could see, and there was a ulcerated lesion from which the biopsies were taken. The second part of duodenum was roomy, and we obtained biopsy from the normal mucosa also. The second biopsy showed neutrophils, eosinophils, no dysplasia, malignancy, there was evidence of some crypt hyperplasia, plasma lymphocytic infiltration, no evidence of H. pylori infection. So the impression was chronic duodenitis. Again, we were not satisfied, but then the option was because patient had already had 2 biopsies, so we thought that let us give her a double dose PPI and observe her. Any new diagnosis somebody wants to suggest at this stage? You have a patient, young patient, 26 years, gastric outlet obstruction, ulceration in the third part of duodenum, significant disease with narrowing of the third part. 2 biopsies negative. Anyway, I think we go ahead. So we got the serum gastrin done. Normally it's 115 to it was 257. It's mildly elevated, twice elevated, but in ZES we get very high values and patient is on PPI. Most of the times difficult to make the patients off PPI for 2 weeks or so. Immunoglobulins, IgG, IgA, ANA, P ENCA, C ENCA to find out about vasculitis were there. And after period of 2 months, 45 days literally, we got another endoscopy done. That's our third endoscopy. So this endoscopy also showed that there was an active disease. You can see the amount of fluid which is there. So there was significant obstruction. Actually, it had shown the same finding of active disease. Forward कैसे करें? Forward कर दे. ये edit नहीं किया क्या इसका?
Sir, did you do serum IgG4?
IgG4 was not done. Yeah, IgG4 was not done. So again, you can see ulcerated lesion, nodular mucosa this time, little bit of proliferative mucosa, significant narrowing, no response to double dose of PPI. नहीं ये हो गया ना दिस टाइम हिस्टोपैथ इसका रह गया ना I think now you should be given chance. Come in. I'll request Kamiani, please.
Thank you so much. Third biopsy, yeah. So in third biopsy in the duodenum, we started seeing some ulceration in the second picture with some ulcerations and some neutrophils has started appearing on the surface. And again, there is a flattening of the villi, absolute bald duodenum. So villus abnormalities is noticed with a dense plasma lymphocytic infiltrate and the surface neutrophils. So this gave us a clue to think about Crohn's. And then we reviewed the first slides. We removed the first slide and reviewed both the things. So we saw there is a definitely villus abnormality with chronicity, plasma lymphocytes, neutrophils started appearing on the surface. And we started thinking, why are we missing Crohn's? The problem with the duodenal strictures when they appear in the first part, usually we try to get the gastric biopsies to overlap so that we can rule out H. pylori or peptic disease ulcers, which are usually round, and Crohn's are serpentinous and fissuring kind of ulcers. But in this, the stricture was in the third part of the duodenum. And we were not expecting, and with third part, distal duodenal Crohn's disease are usually presenting with ileal and colonic involvement as against the proximal part. So we never thought of Crohn's in all this time. We were just thinking of some other lesion. Is it a peptic disease? It is some kind of H. pylori infection which we are not diagnosing, and that's why we are getting these ulcerations. So with this time, first time we started thinking of Crohn's, and there is also a pseudopyloric metaplasia is noted in the adjacent polypoidal mucosa. So with the third biopsy, it is the first time we started thinking of Crohn's, and Crohn's appears as a differential, and later on with the sir we'll go with colonoscopy, then I'll come back again. So
colonoscopically, morphologically was normal, but then from the ileum we got a biopsies. Ileum and colon.
I also include but in ileum, this is a colonic biopsy, and in ileum also we saw that there is not included picture, but in ileum also we saw irregular flattening of the villi, villus dystrophy, crypt hyperplasia, diffuse infiltration of plasma lymphocytes with eosinophils, and very particular finding which we observed in ileum is a hypertrophy of muscularis mucosae, which is going and with some fibrosis creeping into the lamina, which again confirmed our possibility of Crohn's. And in ileum, in colonic biopsy, we also saw this diffuse kind of plasma lymphocytic infiltrate. So we saw a disease where the duodenum is involved, where the ileum is also showing similar morphologies in colon. The most diagnostic picture for Crohn's disease is we want to see some microgranulomas, epithelioid granulomas. But though the rate biopsies is almost 50% will show, but unfortunately they start appearing in the submucosa, which is a deeper part. And in endoscopic biopsy, we usually miss that deeper part of submucosa, and we miss the typical granulomas, which can on the first time clinch the diagnosis of Crohn's. So what are the subtle changes we should observe? One thing, she was a young female. She was presenting with the duodenal strictures. So I think Crohn's should have been in a very high alert. We should be in high alert with Crohn's. So we could have catched that in the second biopsy, not even in first, but at least in second biopsy, because neutrophils is an unusual picture which cannot be seen in celiac diseases or tuberculosis, which can appear in inflammatory bowel disease like Crohn's. So that would have given us a clue, even in absence of submucosal epithelioid granulomas. So this is a very a learning process for us also, that whenever we have something unusual presentation and we get a duodenal biopsies with this kind of picture, Crohn's should be in our differential.
Thank you. Thank you, Kamyani. So basically, this was very unusual that you have a duodenal lesion, but the colon was normal. So then, because to start empirically, even if you think clinically that this patient has Crohn, in a young patient of 26 years, to start empirically with treatment for Crohn's lifelong is sometimes very challenging. So unless until you have the histological diagnosis, very difficult to challenge. And as you said, Crohn's, 40% of people will only have granulomas. So absence of granulomas would not exclude a diagnosis. Of course, I can agree that most of the times you don't have clinical picture and you don't get to discuss with the endoscopist many of the times. So she was started on prednisone and azathioprine as a treatment of Crohn's disease. May she was doing well. June was well. Early satiety. September, iron deficiency anemia. Dose of azathioprine increase. Again, after a period of 1 year, literally after 1 year, she had abdominal fullness, fever. Hemoglobin was good, but little less. Counts were normal. She had fever, so routine workup was done, which was normal. The fever continued, vomiting was there, so we thought that whether it's a recurrence of the disease or so again the endoscopy was done, which again showed a persistent activity there in the third part of duodenum. it again showed ulcerations. So now we started thinking that this patient is not responding to steroids, and we have to do something else, like starting her on biologics. And starting her on biologics, so then we started thinking that should we get her CT scan, because she is young, 26 years old. And so you can see here there was a food material which was there, and by the side of food material there were ulcerations and narrowing. The CT chest was done. It had shown some scattered shadows, infiltrates, and tiny nodular lesion, suggestive of infective process, benign lymphadenopathy, which we didn't think significant. So the bronchoscopy was done. Dr. Dande is there? Nine, no? Oh, in fact. The bronchoscopy was normal, but the lavage was done. And I'll skip because he's not there. The bile fluid was there was no growth. But the gene expert showed that patient had tuberculosis. So I don't think that she has tuberculosis of the duodenum. You want to comment, please? Yeah, please come. Yeah. Bronchoscopic findings.
Start. Yeah. Basically, the patient was having the findings in the CT. There were central nodular opacities. Also, there were some tree in bud appearance. And the patient was of CD. So we were expecting something, because the patient need to start again with some biologics. So accordingly, we evaluated the patient, and suspecting there may be reactivation. That's why we done the bronchoscopy just to evaluation. And the microbiological finding the sir has already described, that the patient came CBNAT positive in the MTB. Also, we were suspecting some non-tubercular bacteria. That's why we also done the CBNAT test. Yeah, that was the only thing. We just to rule out any reinfection before starting and proceeding to the treatment, if we are planning for any newer kind of treatment like biologics.
Thank you. So, Azoran was stopped. Patient was put on 4 drugs of ATT, and budesonide was started. Now the next option is biologics. Which biologics and small molecule? I think that we will discuss. I'll just review the literature of duodenal Crohn's. It's not very common. 0.5 to 4% of total Crohn's disease, maybe higher incidence as per because many are asymptomatic. Majority of the times it is associated with ileocolonic Crohn's, or sometimes the ileocolic disease develops later. The common sites are antrum, pylorus, and proximal duodenum in 60%. Usually it is seen that younger patients would develop duodenal disease than elderly population. All the parts of the duodenum are involved. More common than stricturous disease is more common than penetrating and fistulizing disease. Majority of the times it's a single stricture, multiple in less number, nodular ulcerated mucosa. Majority may be asymptomatic and may be detected. When you diagnose colonic Crohn's, you do an endoscopy and you will be awarded with the lesion. Symptomatic upper GI Crohn's without ileocolic is not common, and our patients had a normal colonic mucosa, though histological. So it's a learning point that even if the mucosa is normal, you should obtain biopsies. The symptoms are gastric outlet obstruction, bleeding and anemia are less common. Differentials we already discussed. CT enterography and MR are the investigations of choice. Mucosal nodularity, cobblestoning, stricture, thickened folds and poor gastric emptying. Endoscopy, the ulcerations can be aphthous, linear, serpiginous, transmural inflammation. The absence of granuloma does not rule out Crohn's and obtain multiple biopsies. Acid suppression for PPI is advocated. Biologics should be considered, especially in young patients, because it's considered as severe disease. And when you have a young patient like fistulizing disease, similarly, if you have a proximal intestinal disease considered as severe disease. Surgery, by and large, proximal, it's difficult to perform surgery, but mainly it's three types: resection anastomosis, bypass, and stricturoplasty. So bypass is supposed to be better than the other forms of surgery, but rarely it need to be performed in less occasions with the availability of so much medical treatment. Thank you. I exceeded my time, that's why I had to run through because it's a long. Basically, I think patients, when they tell, sometimes it is difficult for them to identify, because the lesion was in the third part, beyond the ampulla of Vetter. So clinically, I don't think we should give much importance to these symptoms.
And if your PCR TB is positive up there,
Yeah.
then it is impossible for us to rule out tuberculosis.
Yeah,
Which
basically what I feel is she has been given azathioprine and steroids. So tuberculosis is the effect of treatment that she develops subsequently rather than, because as such tuberculosis in the proximal small bowel again is not very common. Secondly, persistence of lesion there, asymptomatic patients in between for a period of a year, there was no history of fever also. One can always.
No, I fully agree that the clinical details to be given to the pathologist becomes
Yeah,
so important,
very
because so
important.
many times Crohn's is diagnosed by clinical findings
Yeah.
from the clinician actually. And in this case, it was more Crohn's than tuberculosis.
So, sir, this patient is currently getting AKT as well as steroids, or?
No. Basically, we have stopped immunosuppressions. We have started budesonide
Okay.
to have a control of her disease activity, and AKT is started. Once after a period of 1 month, when the active infection subsides, then I think we should put her on biologics, and if given a choice, I would think of doing ustekinumab, which has less immunosuppression. Vedo also is another choice. Tofacitinib does not have any Crohn's, but upadacitinib is a new small molecule which is also effective in Crohn's, but likely to be available in India. So choice will be between ustekinumab, vedolizumab, and a small molecule. Yeah.
Hi, sir. Very nice case and a difficult diagnosis. So my question is, did you consider exclusive enteral nutrition for this case, in case you wanted to give ETT and take control of Crohn's also?
I don't remember the weight of the patient, but initially we had put the NJ tube beyond, but now actually if we consider that there is activity of the disease, in fact this has happened about 4 to 5 days back. The patient is put on anti-TB, means on telephone only we told her that your report has come positive, so we are sending you the prescription. She is going to come, and that time we will decide, looking at her nutrition, that whether we should be putting NJ tube for a period of month or so, or some feeding jejunostomy.
Yeah, I think you meant limiting nutrition for Crohn's treatment per se, is that right? So she's actually quite malnourished. So that's one issue with her because her vomitings persisted, and the biologics and the patient's desire and affordability are challenges. But I think with duodenal Crohn's, we need to be top down and we have to be aggressive in treatment. So these patients clearly did not respond to 75 milligrams of azathioprine for her small body weight. So she will require biologics. Unfortunately, she's developed TB, but ideally infliximab is your best choice. Not much head-to-head comparisons, but the overall infliximab gut feeling is that it's a better molecule. But with TB now, I think we'll have to do, as Sir said, insticanemab Stelara is what we have started on about 5 patients for Crohn's with Stelara at MIDAS. So we've been using that quite a bit with some good success, so yeah.
So I meant to say for the induction part, she has not responded to her steroids.
Yeah.
She was on azathioprine also.
Yeah.
She has an active disease and there is a concern of TB also. So would be very difficult to give biologics, as Sir said.
Yeah,
for
that's
that,
why actually
Ustekinumab is a good
our
one.
first choice is ustekinumab. Anti-TNF would be having more immunosuppression and the more flare-up of tuberculosis. So we would not give it as a first choice. And in fact, ustekinumab has also been shown to be better in those patients who has not responded to infliximab. So I think it's a first choice.
Sir, non-bilious vomiting,
Yeah.
Non-bilious vomiting could be explained by the fact that the vomiting was because of the gastric cause, not because of the duodenal obstruction. So the vomitus was not bilious. That can be explained.
Patient had gastric stasis, but the gastric stasis was secondary to third part obstruction because you can see the third part being narrowed significantly.
Okay,
So the obstruction was beyond the ampulla.
but the bile was not coming in the vomitus, no?
Yeah.
So what could be the...
Majority of the times what happens is all these histories we ask, we don't give much importance to, patient doesn't give much importance to looking at the vomiters and discriminating whether bile is there or not. So that must be the reason.
Yeah, we have online chairpersons also, we can have their opinion. Can we connect to them?
Yeah, I think they're on. I think they'll just have to
Yeah, hi.
unmute. Yeah, I think that's Ankit. Yeah.
Yeah, hi, sir.
Arun.
So, no, it's a very interesting case. I mean, to have duodenal Crohn's is very unusual, and treating and managing it is difficult. I think right now the best way would be managing nutrition and giving AKT so that the infection bit settles down. And then you can, I think, after a month or two, once the nutrition picks up, the weight picks up, then maybe you can start some biologics.
Yes, thank you. Thank you. No, it's agreed. So I guess
Thank you, sir.
we can move next. Sorry.
Dr. Tome, can you have one
Yeah, I think,
mic?
So I just want to ask you your experience regarding how many patients of such kind will get both the treatments. In most of the discussion, we find that they have at some point of other received AKT as well as Crohn's treatment.
Yeah. Majority of the times, if the patient has received AKT, then we are almost sure that the patient has Crohn's disease. But Crohn's disease, developing tuberculosis, one has to also see that tuberculosis doesn't get flared up. And at times, the situations is there that we cannot have full immunosuppression. So give the patient after covering for anti-TB, then you can probably go ahead with drugs which are having inflammatory bowel disease activity but less immunosuppression. That's why vedolizumab or ustekinumab are the drugs which are considered.
Thank you, sir. We move on to next case. New therapy added to MIDAS armamentarium for management of PD stones. I invite Dr. Bhushan to present the case.
Yeah, good evening to all the chairpersons and all the delegates here. Yeah. Yes, sir. So, yeah, we have a nice treatment now for management of pancreatic ductal stones. So let me begin with the Yeah. So he's a 21-year-old male, which is diagnosed to have a chronic calcific pancreatitis since last 2 to 3 years. The current issue with the patient was having recurrent episodes of abdominal pain, and the etiology was really idiopathic. The patient currently, when presented a couple of months back, was not having any exocrine or any endocrine insufficiency. So this was a CT scan that presented to us from outside, which showed that the pancreas is count atrophy, the duct seems to be dilated, and you can see the calcifications seen in more of the head and the body region. So added option of a young male who presented with a symptomatic, painful, chronic calcific pancreatitis. The options was discussed with him in the form of an endoscopic treatment and surgical treatment. And really at that moment of time, we found that, okay, the stones are more in the head and the body region. We definitely would have tried an endoscopic treatment. And also explained to the same through the relative regarding the prognosis of both endoscopic and the surgical management in the form of both short-term and long-term outcome. So really patient offered at that time deferred surgery at that moment, and we really promising for one endoscopic treatment which is called an ESWL. Before that, we really want to do what is the content of intraductal, what is exactly an intraductal stones in these patients. So we did an ERCP. As you can see on fluoroscopic image on left hand side, the stones are really, it was more in the head and the body region. So it was not like an entirely that what is seen in CT scan, it is more into the parenchymal stones also. It was not like an entirely the pancreatic duct was filled up with the stones. So it is more in the head and the body region. The stones was more or less in, it was a radio opaque stones. So I did an ERCP, as you can see. It was a very large stones which is seen in the more in the head region with a few filling defects with in the body region, and there was no associated any strictures present at that time in pancreatogram. So I did a large pancreatic sphincterotomy, and one 10 French stent was placed across the stones up to the body region. So then we definitely, the one endoscopic treatment which is added into an armamentarium in MIDAS is an ESWL treatment. It is called extracorporeal shockwave lithotripsy for pancreatic duct stones. We have a Dornier delta electromagnetic lithotripper. Usually it is performed with an epidural anesthesia, and on an average the session which has been performed in literature is around 3 sessions, though can extend up to 5 to 8 sessions depending upon the burden of the stones. Most of the stones, as you see, are radio opaque stones, but since some patients who are having a radiolucent stone, we can do a nasopancreatic placement to an ERCP, and then we can target the stones and for ESWL, and thereafter may or may not depending do an ERCP. The aim of all the ESWL is to fragment the stone size to at least less than 3 mm, so that they can pass off through an papilla, and we can get rid of that stones. So we offered the patient for an ESWL, and as you can see, we did a 5 session of ESWL in this patient. So we can see, though I don't have a very nice image, but what I can have, as you can see, the stones which was seen on fluoroscopy in the head and body region is almost as fragmented. And this is a very nice pancreatogram with what I did. As you can see, the duct appear completely cleared from a pancreatic duct stones. So I offered a completely stent-free trial for this patient. I did a ERCP thereafter after 5 sessions of ESWL, and the stones which were seen in the head and body region was completely the duct has having complete clearance of an duct by as seen in pancreatogram. So this post-procedure patient is doing absolutely well. Currently 1 month follow-up has been done. Patient is completely asymptomatic, at least on telephonic conversation with us. So this was a nice young male for which we performed an ESWL procedure and get rid of complete ductal clearance was achieved and also given a stent-free trial. So it's another second interesting case of an 40-year-old male who is having a chronic calcific pancreatitis secondary to ethanol abuse, which has stopped since last 6 months, was symptomatic for abdominal pains for last 3 months. This patient was having steatorrhea by the time of presentation. Sorry, we don't have an images for this patient since the patient was just came with an CT without any films. So we did a outside CT which was reported to find an dilated MPD with an single intraductal stones in the head region. The ERCP was attempted outside, and we have it was reported that there was a single stone in they had achieved a pancreatic duct cannulation, but the main deep pancreatic duct cannulation could not be achieved because of a large stone which is seen in a single large stone which is seen in the head region. So with that symptomatic, again a symptomatic single large stone, uncomplicated, the patient presented with us with a pain, and we also attempted an ERCP. The problem with ERCP was there been definitely inflammatory narrowing at D1, D2 junction. That's why the scope could not be negotiated beyond it. So yes, I can really ask Dr. Saurabh sir to just have one listen.
Yeah, good evening, everyone. So we have Dr. Ankit Dalal online, who's an expert endoscopic endosonographer. So hi Ankit, and Dr. Arun Iyer as well, who's a great gastroenterologist from Raipur. So this patient actually also not mentioned in the prior CT he had pseudocysts as well, at least one cyst which was fairly large. So this patient had inflammatory narrowing of the duodenal bulb, a pseudocyst, as well as a stone in the head of pancreas, and was quite symptomatic. So in this instance, we decided to start with ductal decompression, and since ERCP was not feasible, we decided to go ahead with EUS guided pancreatic drainage. And here we are looking at the EUS view of the pancreatic duct. We gain access from the stomach inside the pancreatic duct. Now, these are some of our newer videos, so we have some limited videos as we just moved to the new center. But you can see the needle is in the pancreatic duct, and let me see if I can fast forward it. Can you do duplicate show 1 second? I think this is better if I do duplicate. Yeah, sorry, let me just do it again. Yeah, better. So let me just fast forward, yeah. So here we are gaining access across the gastric wall inside the pancreatic duct, and 1 second, this is restarted. Okay, so here's what happened. So we are placing the duct, the stent inside the pancreatic duct, and everything looks good. This is a stent from the stomach going inside the pancreatic duct, but unfortunately, we encountered a very unusual and a unique problem. With these stents, when we are deploying, the guide wire goes through the stents, and this guide wire actually got stuck inside the stones in the pancreatic duct. So here we go. So I'm trying, it's just not getting out. So now really we were sort of stuck there with the guide wire stuck inside the stones through which the stent has been loaded. Everything has gone fine, but now I just can't get it out and deployed. So this was the problem we were encountering. And we have the X-ray. Yeah. Should we have the X-ray before? No. Okay. So basically the guide wire was left in place, and we said, okay, now what can we do? And one option was to cut it and leave it inside the stomach and figure it out at a later point, because somehow the pancreatic juice will drain. Surgery, obviously, but there was so much inflammation, pseudocysts, stones, this, that, so that was the other issue. And this patient, in fact, I was planning for ESWL up front, but because of the presence of pseudocyst, we could not do the ESWL. I think we did not put this in the video over the pseudocyst drainage. But what I did was I said, okay, let's plan for maybe ESWL for this patient. And we went in, And because ESWL should not be done in a patient with pseudocyst, that's why we did not do it up front. So I went in, I left it alone, and I went in and removed all the cyst, aspirated it. About 100 cc of fluid was aspirated and decompressed the entire cyst. And then we said, okay, now what can we do about it? We looked at these different options. And then we said, maybe now that I've drained the pseudocyst, let us plan for an ESWL attempt. So I think Bhushan will take forward from here.
Yes, as sir said that the wire and the stent got stuck inside, and we kept that wire, whatever guide wire, along with the stent inside. And since we can't able to remove it, we sent the patient upstairs from an endoscopy suite to the ward, and called on next day with the same guide wire in the mouth, and we perform an ESWL. In single session of ESWL session, the stone starting fragmenting, and both the wire can then we can easily remove it, and even the stent get externally migrated. So I am very sorry to get and procure the image of that post ESWL, but the stone which I hope you can able to see, it was a single large stone in the pancreatic head region, that is what not allowing us that a deep PD cannulation. So this patient did an ESWL, almost couple session was performed, the fragmentation was achieved, and both the stent and wire was very nicely removed. And this patient has achieved a fragmentation of stone, was discharged, and was scheduled for follow-up ERCP once that inflammation of D1, D2 start, and we may plan for an ERCP and just confirmation of pancreatic duct clearance are thereafter. So yes, so for a management of any uncomplicated, painful, chronic calcific pancreatitis, it will always start with definitely a lifestyle modification first in the form of abstinence of tobacco, alcohol, and analgesics, and in the selected patients, an endotherapy in the form of ERCP, basically an ESWL pancreatoscopic laser for pancreatic duct stones, and followed by a sequential surgery. If the patient at that moment, if the patient having a diffuse stones or multiple strictures out there, surgery can be offered at front. So as you all know that 50% of patients of chronic calcific pancreatitis has the stones at the presentation, and stones mostly which is seen in our part are mostly of a non-alcoholic etiology. They are mostly an idiopathic. They are having a larger and denser as we all know, like a tropical calcific pancreatitis. So inner nidus is always surrounded by the successive layers of calcium carbonate. Majority, as I say, is a radio-opaque stones. 20% are radiolucent stone. So any patient who presented with us with a symptomatic painful pancreatic calculi, if you have a small calculi, we can do an ERCP and extraction with a balloon or basket. If the stone having a large calculi, then we do a cross-sectional imaging to locate whether the stones is having in the head, body, or whether either a single or multiple, or whether also should a stricture or not. And accordingly, if the patient having a located stone in the head and body, we perform an ESWL, ERCP, and if the patient is not amenable for ESWL, ERCP, we do an pancreatoscopy and laser and achieve a duct clearance. In spite of that, the patient have failed, we can't able to achieve a ductal clearance, then we offered a surgery. So if the patient is having an extensive calculi right upfront, multiple calcifications, multiple strictures, and suspicious head map, definitely a surgery is an upfront for such patient. So what are the ideal, what we can see when this patient, what are the ideal candidates which are really having achieved best results are the one which having a large pancreatic duct calculi, especially in the head and body region, with the pain as a dominant symptoms. So these are the very ideal case that we can have a target for ESWL. And the aim of this patients for fragmentation of the calculi to less than 3 mm. So as also we should know what are the contraindication for ESWL. So the patient is having an extensive burdens which is entirely seen in the head, body and up to the tail region, multiple MPD stones, MPD strictures, presence of moderate to massive ascites, presence of pseudocysts as mentioned, that sometimes targeting of the stones can be a challenging when the patient having a pseudocyst, and definitely a pancreatic head mass, pregnancy, cholangitis or coagulopathy these are the contraindication of ESWL. So these are what I can see if someone like it's a cross-section imaging. This is a nicely dilated pancreatic duct and we can see a nice single stone in the pancreatic head region. So these are the very nice ideal candidate who are benefit best from the ESWL. So these are something like for presentation. These are the calculi in the head region. In the A image, in B image, we can see calculi in the head and body region. These two are the very nice ideal candidate for pancreatic for ESWL. For calculi in the head, body and tail region, definitely I will recommend it a surgery as a better options than this ESWL. So to just, this is a very nice study from a single center from AIG Hyderabad, for which the ESW was performed for more about 1,000 patients, in which they achieved a complete clearance for around 76% and partial clearance was in 17%. And in short term, at least they have mentioned a 6 months follow-up was done in this study. They have found 80% has a pain relief with a minimal acceptable complication. For the same patient, they get an extensive follow-up, and their follow-up was extended for another for another 12 to 18 months, and they said that out of around 2,700 patients, 80% has achieved a complete clearance and around 13% partial clearance, and 770 patient does not have the ESWL was not able to fragment the stones. So these are the very strong literature. And then the same center came up with a very extensive data of 5,000 plus patients for pancreatic duct stones, and in which the complete clearance was achieved in 72%, partial clearance was seen in 17%, and different 10% stones were non-fragmented by ESWL. And in this patient, at least 6 months, again they done a 6-term short-term study, and the pain relief what they are given as 82%, with a minimal acceptable complications in the form of mild pancreatitis, an ecchymosis on the skin surface, and some minimal abdominal pain post-procedure. So this is the same patient. They follow for another 2 to 5 years, and some group were follow for 5 to 8 years. And what they have been come up with an intermediate data that complete pain relief was seen in around 70% of patient at the age at 5 years follow, and 60% of patient for at long-term follow. So definitely at 8 years follow-up of this patient, what they have done, they have found that 60% of the patient has achieved a complete pain relief by using a complete duct clearance using ESWL. So these are some other studies for which the ESWL has been performed, and according on all the studies have seen that complete clearance of duct is achieved in around 60 to 70%. Pain relief was seen around 60 to 80%, and the follow-up, which has the maximum study, was ranging from 6 months to 8 years. So definitely has a very strong promising data of this patient who is having who has benefited from ESWL. So even for this, even the ESG guidelines also suggest that any radiopaque obstructive MPD stone which is more than 5 mm and it is causing symptomatic, ESWL should be offered as an upfront for management of such stones, and considered pancreatoscopy laser when ESW is not available, or stone that were not fragmented adequately after ESWL. MPD obstruction located only in the tail of the pancreas are not considered for ESWL or any endoscopic surgery, any endoscopic treatment, and as such patient should be offered as a surgery. So as a take-home message, as you all know that pain in chronic calcific pancreatitis is not only caused by the intraductal pressure, there are multi-factor etiology. For the patient who's having a symptomatic stones, dilated MPD, stones more than 5 mm, ESWL with or without ERCP has excellent clearance rates with a good relief of pain. In properly selected patient, ESWL should be offered as a first-line therapy for all large MPD calculi which is not amenable to standard techniques of stone extraction. And definitely, a multicentric RCT definitely is required for further exploration of ESWL and making it as a main line of treatment for stones. Thank you.
This ESWL is an age-old therapy for the renal stones. Why do you say that this is a new therapy? Has this been employed for pancreatic duct stones recently, or your institute has got this recently?
Yes.
What is the?
At least from the last decade, the ESWL has become popular for pancreatic duct stones. In our MIDAS hospital, this has been, it's been a first time that the ESWL has been applied, and that's why we are calling it as a newer therapy in management of pancreatic duct stones.
No, actually it's, so
Yes.
the ESWL as a therapy for kidney stones obviously exists and is widely available, but the equipment that's available is not effective for pancreatic stones. And therefore, throughout the central India, no center actually does ESWL for pancreatic stones. So people have to travel either to Mumbai, Hyderabad, Delhi, etc. for getting ESWL for pancreatic stones. Now, we wanted to discuss this as a new therapy that now we have it available, not only for MIDAS, but the entire central India. We have the opportunity to do ESWL for all these chronic pancreatitis patients. And we have had remarkable results in all the few cases that we have done. And, I thought it was worthwhile to discuss which patients to do, which ones not to do, because we have pancreatoscopy, laser, which is another endoscopic option. We have ESWL, and obviously surgery, which remains another mainstay for therapy. So I think choosing wisely which therapy amongst all the possible options for treatment that we have now would be something worth discussing, so we all understand which are the right patients for ESWL or pancreatoscopy or surgery here.
And how is the lateral damage because of the power you use to break the stone? Because pancreas, if you have more injury, then there will be injury to the
Yes, sir.
pancreas.
That's why the stones which are more in the tail regions are not been targeted. That's why it is one of the relative contraindication. If the stones having in the tail region, that may cause a splenic hematoma, splenic rupture, is also been reported in anecdotal cases. So that's why the stones which are more in the head and body region are targeted. And also the complication and rates are very, very minimal, sir. As per all the reports and this, all the studies, it's just like around 5 to 10% of complications. No major complication in the form, as you mentioned, like any bowel perforations, biliary hematoma, or a splenic hematoma. It has been reported but in a very anecdotal type, not like a very severe type.
Because in renal calculi, this is not a preferred choice nowadays because of this lateral damage they used to cause.
Yeah.
So similarly in pancreas also, I wanted to know.
Yes, sir. But the reported is not like, as you say, it's not been removed.
Bhushan, what is the interval between two sessions?
Sir, mostly we 24 hours. We keep a 24 hours of interval.
And what is the cost of ESWL?
Sir, we are we are costing around, I think, 10 to...
Total 3 sessions,
three
about
session.
50,000 rupees for 3 sessions.
Bhushan sir, I had a question. The second case, the ethanol related chronic calcific pancreatitis, that patient had D1, D2 narrowing, so ERCP is not possible. What I want to know is, can you get away with just doing an ESWL? Because there have been reports saying that the ultrasonic waves, they help in pain relief also. So, is it possible that you might get away without doing any ERCP in this case?
Absolutely, Rutvik, no problem. The data is like one randomized control trial is also there, that patient with ESWL alone has produce a similar rate as compared to patient having ERCP and the PD stenting also.
No, I think this patient had a large pseudocyst. And that was the primary reason to attempt a ductal drainage as opposed to direct ESWL. That was the main issue, I think, which was somehow not captured in the story.
One issue would be that the stone should be fragmented to less than 3 mm, Rutvik. That's the problem. If you're able to fragment that stone to less than 3 mm, and the patient remains asymptomatic, definitely we will not require a sphincterotomy to do and achieve a PD clearance for that. Definitely.
Yeah, any comments from our experts, Dr. Arun and Dr. Ankit and Dr. Kailash, please?
Yeah, I think Ankit has a lot of experience at BIDS with ESWL, so we'd love to hear from you, yes.
Yeah, so we've been doing ESWL for I don't know how many, maybe 15 years or more. Dr. Maidev, I mean, I've been at BIT since the last 8 years, and sir has had that machine for ESWL dedicated for pancreas for over 15 years now. So yeah, we do have a lot of experience, and as Saurabh said, it's a wonderful therapy for pancreatic ductal stones. If you select the right patient, the right indication, I think you can avoid surgery in most of the cases. Yes, pancreas ESWL is much different than renal. You need to give different settings, different power, higher number of shocks. But really, we don't see any complications, especially if there is no active inflammation going on. If you have inflammatory process going on, there are pseudocysts, there's ascites, then it doesn't work well. But in a quiet patient of chronic pancreatitis, ESWL works really well. And nowadays we are in fact seeing that with ESWL, you can just crush the stones completely and maybe avoid an ERCP as well. You don't need to drain the duct because the stones become so small, they flow out on their own and the patients become pain free. Only thing I wanted to ask Saurabh about his case, if he can tell me. So your wire got stuck. Were you using a VisiGlide, and were you trying to go towards the tail, or were you trying to go towards the head from the puncture site?
No, we were going from the gastric body towards the head, where the stone was actually. And
Okay.
as getting the guide wire deep, it got stuck inside the stones.
Yeah.
Which wire? I don't typically use VisiGlide. I think must be a 030, one of those hydro. I think the thermo
Yeah.
wire. I think that's probably what we were using. Not the
Okay, okay.
not thermo. Sorry, not thermo. Taiwung wire 03 guide
Okay.
wire. Yeah.
Okay. Okay.
Congratulations to MIDAS for acquiring this new therapeutic armamentarium, and I'm sure a very large number of patients will be benefited. I think we now move to the next case. It's to be presented by Dr. Saviour himself.
Okay, so moving on, I think a little different flavor. We've been covering different aspects of GI, IBD, then we had pancreas, and now we have a GI bleed patient, more liver now. So this is a 51-year-old female. She had history of diabetes, hypertension, decompensated liver cirrhosis, likely due to NASH. She had multiple episodes of decompensations with GI bleeding, and prior to presentation, she required endoscopic band ligation in December 2023. Hysterectomy in 2014. Now she presented with hematochezia. She initially was at an outside center where a colonoscopy was performed and revealed fresh/altered blood at terminal ileum, and they could not find a source of bleeding. An upper GI endoscopy was also performed, and that was negative for source of bleeding as well. They did a CT abdomen there and showed normal mesenteric angiography, CLD, and mild ascites with contrast study. So again, they could not find any vascular reason. So the patient was referred to our center because she just kept on bleeding, and her anemia persisted. So on examination, she had pallor, edema, tachycardia, moderate ascites. She was kept in the intensive care unit, and you can see this is January. She was transfused from 5.6 going to 9.4, but then persisted with bleeding constantly, 5.6, 5.2, requiring transfusions. Renal failure wasn't there, and electrolytes were okay. Bilirubin was fine. So we did a CT abdomen and performed one at our center. And now you can see, I'll show you what this patient had. I'm just going to pause for a second, actually. Let me do this. Okay. You see? Yeah. So we did a CT abdomen, and we are looking at the pelvic cuts. And, right, okay. And so this is an ectopic varices this patient had. It's a small bowel, and the rectum is at the bottom. So I'll just show and pause it again. Right, so this is the rectum at 6 o'clock. There's an ectopic varices, as you see in the left of the screen, and then you see the small bowel. So this had a tuft of varices which was communicating with the small bowel suspected, and was actively bleeding. That was felt to be our source because everything else was negative, and she was actively, profusely bleeding. Now, as we see in a lot of our patients, cost was a big barrier, and to go ahead with further studies, we did a EGD that time, and again, colon, which was negative. Actually, this was done prior to the CT. So really, I think we had very few options. Persistent bleeding. This was a lesion that was found. Capsule endoscopy was previously entertained, but now with that, varices was discounted. So considered TIPS, cost was a big barrier, so the patient was absolutely not able to afford. We figured we can do angiography or access. I don't think Tejas is here today, who did the procedure eventually, but that was one consideration to gain access, or even surgery at the last resort. So everybody sat together, we discussed, and we let our interventional radiology, Dr. Tejas Sadavarte, try and see if he can locate the source and intervene. He managed to do an arteriogram and tried in that manner to go and access the veins, but he could not. And portal vein access, there was a lot of ascites actually. So he did not want to attempt a portal vein access. And surgery was obviously high risk, and therefore we discussed and considered maybe with the US if we can somehow find it and address it. It'll be nice. So this is the, I'll show you the video. So we went across the anal canal, and there was actually large amount of ascites initially, and we barely saw this lesion when we started. But then I sent her back, and we removed about 4 liters of ascitic fluid. Then ultimately, we could identify this ectopic varices. We went about 15 centimeters across the anal verge, and you can certainly see a lot less ascites, but it required a lot of manipulation to get the perfect angle with less ascitic fluid. And we went across with a needle and managed to place a 15 millimeter coil and 3 cc's of glue, which was then injected to obliterate the varices. The patient actually was extremely ill. She was constantly on vasopressors, NORAD, about 10 of NORAD, cirrhosis, active bleeding, constantly requiring blood. So this was, I think, our best option. Going retrograde enteroscopy would have been was not viable really with the way she was doing clinically. So you can see now there's the flow has stopped in that vessel, and I'll just end it there. So actually the patient amazingly well, symptomatically improved radically, and was discharged on the 3rd day. We did a telephonic follow-up, and we are now in April, so this is about 3 months now. And the patient is doing well, has had no further bleeding episodes, and she's following with a gastroenterologist locally for further care. So when you talk about portal hypertension, varices essentially form because the portal circulation, there is increased pressure from resistance from the liver, and therefore wherever the portal circulation is in close proximity to the systemic circulation, there is formation of varices. So esophagus, G junction, the most common location, and it also occurs obviously in stomach, as we are all aware, in the rectum. And so these are your examples of esophagus, stomach, rectum, but then also in small bowel, and then we can find them in unusual locations in colon as well. And this is the data looking at 169 patients with ectopic varices, which end up being only 5% of all variceal bleeding. 26% were peristoma, because you can see stoma, there is systemic circulation, which is close to the portal circulation. That's when the varices form. 17% duodenum, 17% jejunum, 14% colon, and then even unusual sites like ovaries and vagina can happen. So typically management, you would start with IV fluids, PRBCs, portal pressure reduction with octreotide terlipressin, which is all we did in this patient. The definitive treatment really on all these ectopic varices depends on what you're dealing with. If you can access with endoscopy and look at them, then you can put in glue, sclerosants. IR folks usually go via portal vein access and embolize it from the other side. TIPS remains a great option. And then surgically varix ligation or portosystemic shunt creation can be the options. So if you see, this is an algorithm explaining if you have endoscopic therapy, if it's possible, and bleeding is successfully controlled, you start on beta blockers. If the patient has a patent portal vein and endoscopic therapy is not possible, you can consider embolizing. If not, you can consider a surgical shunt or TIPS. And then otherwise, if there's no patent portal vein, then just beta blockers and surgical ligation of varices. So here we've sort of modified this a little bit, where we have added endoscopic ultrasound to guide therapy. in bleeding ectopic varices. What we did was glue and coil, and I think in the previous forums we've shown cases where we have used glue and combination of coil. And you can see this is now getting old data, 152 patients with a large experience in this series, more than 93% obliteration rates. And the reason we do glue and coil is because the risk of embolization with adding coil to the glue, the embolization is reduced. So here you can see in the series with this is left is glue and right is coil. You can see the difference. The complication rates goes down with coiling, and that's the reason we do this. So therefore, ideal is combination of glue and coil when we are treating these varices. Unusual spots with EUS addressed. We have shown, I think, patients with rectal varices being addressed and gastric varices. Now this was a first one for us where we did a transrectal, transascitic, I suppose, peri-small bowel varices. And here are a series of duodenal and colorectal varices which have been treated successfully with EUS. In fact, our case is now actually accepted in endoscopy journal, which is in the European Society journal for endoscopy. So I'll end the case there, and I'm happy to take any questions. Thank you.
Congratulations, Saurav, for thinking about doing EUS. Second thing is, when it was difficult to localize, you preferred to tap her and then take her again. So really good attempt, and for saving her life. Yeah. Any questions from audience and online consultants?
Ectopic varices
Yes.
seem to be there in so many places, like in, for example, in colon and small bowel and all that.
Yes, yes.
More frequently they bleed from esophagus, isn't that? As compared to the bleeding from the ectopic varices. Any specific reason for it?
It probably has to do, the bleeding risk has to do with the pressure inside the diameter of the varix and the wall thickness of the varix. So the three factors that are associated with increased risk of bleeding is high portal pressure, higher diameter of the varix, and reduced thickness of the wall. Now that happens probably most frequently in the esophagus, and that's perhaps the reason why they bleed more. The other thing is presence in the other areas is also less, because the systemic and the portal circulation proximity is less. I mean, you can imagine the systemic circulation is around the anus and the upper GI tract, and that's where the portal and the systemic circulation are very close. So those are the reasons why you have varices in the EG junction and the rectum, mostly. In the rest of the areas, it's less. Can happen. Peristomal, now you can imagine that happening because now you have a stoma and then you have systemic circulation coming close. That's why presence is less. They are there, but overall, what proportion of them bleed, I'm not sure. But when they bleed, it is significant. Yeah.
Going retrograde in such types of cases, considering that there is possibly a bunch of varix in the small bowel, is it the proximity of small bowel going retrograde with EUS that helps you more, or the antegrade wise?
Yeah, no, I think in this particular case, this was deep in pelvis. So the varices was in some ileal loop, which was in pelvis, and it was next to it. And from rectum, on CT, in fact, you could not see it. I mean, it seemed very far. But then I said, I'll give it a shot. I dried her out, and then managed to somehow get a window into next to the small bowel from rectum. Now, if you meant retrograde endoscopy was not feasible because she was on NORAD 10 and very, very sick. So, yeah,
CT is showing
that tough. Yes. Yeah.
Now, answering your question of ectopic varices, whether they bleed more than the conventional, I think it's very difficult because as such people would have normal varices in the GE junction more. Ectopic varices, the incidence is only 4 to 5%.
Yeah.
So less common. And they are at such sites where probably the wall thickness of the mucosa is more, like in colon. So they have less chances of rupture. Yeah.
True. So any
I
comments
must
from, Arun?
congratulate Saurabh because, puncturing a vascular lesion is not very commonly done. So, I mean, it requires lot of guts, courage, and lot of thinking also to puncture a vascular lesion when the patient is on inotropes and things like that. So done a wonderful job, and I could see the patient off vasopressors within 24 to 48 hours when the bleeding was stopped. So this is something outside the gut also. You can with the EUS and targeting the vascular lesions. In fact, we are going to present one portosystemic shunt which was done.
The obliteration option, yes. Yeah, I think vascular endotherapy with the US is now coming of age, and we can now access various vascular lesions and sites from stomach. Pseudoaneurysms, there have been now reports, about at least 10, 15 reports out there where pseudoaneurysms have been done transgastric. So this was something similar. We went across the rectum and ascites. But the challenge here was the distance, and when you're hitting a vessel, the distance from rectum to the varices and the fluid in between, which made it even more challenging. Because if I puncture a needle and if I somehow lose access, the patient is going to bleed in the peritoneum. So then we really had to be extremely cautious, careful that we have the access, secure it, and then deploy quickly the coils so that there's no active bleeding.
Possibly, Saurabh,
Yes,
the
yes.
post-hysterectomy adhesions helped you. It was post-hysterectomy adhesions which were the culprit for causing these varices.
Interesting. That's
She had hysterectomy, and the ileal loops go deep down after hysterectomy into the pelvis. And they get stuck there. And they get stuck there, and that probably helped you. That bowel did not slip.
Yeah.
They got stuck there.
Interesting.
But this was definitely a very smart diagnosis and a very smart treatment. Congratulations.
Yes, thank you. Thank you. Yes, thank you.
I have a question.
Yes, hi, Dr. Arun.
Can you hear me?
Yeah, we can hear you. Thank you.
Very lovely case, and kudos to you, Dr. Saurabh. Just I want to inquire, how do you prevent your EUS scope from being damaged from the glue, and which needle did you use? Which FNB needle did you use? 19 or?
Yeah, we used a 19 gauge Olympus needle, and
Okay.
how do we prevent? So when you're putting glue,
yeah.
So we get access, put the glue, and then pull it out, but don't pull the needle inside your channel. And then you get it, get the needle inside, and then pull the sheath inside. And then get the scope out. So now the needle is obviously gone because you have used glue, so you can't use the needle again. That's how it is.
Okay, thank you.
Yeah.
Thank you, Saurabh.
Ankit, any comments? No, I think.
No, I mean, this is really good. I think the CT helped a lot to know the anatomy. And I think what you did was really wonderful. I think to do this in the condition that the patient was, and I'm 100% that you didn't have any other option. I don't think you could have gone with an enteroscope and do it, getting the varix in position and then injecting glue. It's going to be a tough task. So this EUS guided coil and glue was a fantastic procedure. Good job.
Right, thank you. Oh, Ankit is an expert, national expert in our
Not
EUS
at all.
team of national experts. So, great. Thank you, Ankit. Yes.
Thanks. See you.
Okay.
Thank you, Saurabh.
Thank you.
We move on to next case, unusual cystic lesion by Dr. Rahul Naikwade.
Good evening. Let us move from endoscopy to laparoscopy now. So this is little bit unusual case. This 15-year female child presented to us in the month of January with complaints of abdominal pain on and off of 1 month duration. She has pain mostly after meals, associated sometimes with vomiting. Occasional, she had complaints of loose motions 2 to 3 times. She had past history of appendicectomy in the April 2023. CT I can get, but I cannot get images suggestive of right kidney was not visualized. Rest of the findings were normal. I can get surgical findings suggestive of acute appendicitis, retrocecal, complicated, and some comment about right ovarian cyst was found hemorrhagic. She was alright for 7 months then, but again since December she has these complaints. She was with us on 15th, we evaluated on the same day. She had some tenderness on the scarred area, mild tenderness, her hematology was normal. X-ray, abdomen as well as chest was normal. So CT was done on the same day. CT, you can see upper CT was normal, lower you can see solitary single functioning kidney on the left side, and on the right side there is some cystic lesion well formed in the paracecal area. So this is the solitary hyperfunctioning left-sided kidney, absent kidney on the right side, and on the lateral side of cecum there is well-formed cystic lesion. So these were the findings, and other additional interpretation by our radiologist was intussusception in the arterial phase, but was gone in the venous phase, possibility of stump appendicitis and some adhesive form of lesion might be there, which was skipped. So with this we decided, as she was prepared for surgery and suffering, we gone ahead in the evening with laparoscopy. (5 mm) laparoscope was used to the umbilicus, and some scar adhesions which were expected were removed with bipolar. They were not the cause of her pain, but after removing the adhesions, there was some stump-like lesion, some scarred lesion was seen adherent to the right parietal wall, which on further tracing you can see the cyst which was described in the CT scan. So omental adhesions were there overlying it, that omental adhesions were separated and cyst area was examined. After examining it, I discussed with gynecologist and gone ahead in the pelvic area to examine the pelvic structures. So you can see after examination of pelvic structures, right side of the uterus, right, it was unicornuate type of uterus, and left side there was well-developed ovary as well as left adnexa was well developed. So I shifted again to the cyst, and it was hemorrhagic ovarian type of cyst, which I conclude after separating it from the cecal area and ascending colonic area. Till then I had to go ahead to the radiologist, discuss with him on the phone, is this possible, is this a ovarian cyst or any other inclusion or other type of cyst. So I was able to enucleate the cyst completely. After enucleating it completely, it was typical hemorrhagic ovarian type of cyst. So I had gone ahead with complete enucleation. As gynecologist suggested, we have to preserve the ovary. So this you can see after removal, in continuity with that, this is the ovary behind, and in continuity with this is complete portion of this ectopic type of ovarian lesion. So being young patient, I have to preserve the ovary. So after enucleation, the parenchyma of the rest of the ovarian tissue was again sutured for hemostasis. Then thorough wash was given, and after confirming hemostasis, any other pathology in the small bowel, I decided to better fix the cecum because ileocecal junction was very excessively mobile in her case. So I had given 2 or 3 stitches to fix the cecum, but have some part exposed of the ovary for future examination, and abdomen was deflated without putting any drain. So post-operatively, we had again some menstrual history and other history from her parents, and she was history was normal. She was discharged on the second day. So final diagnosis we placed like post open appendicectomy case with right ectopic paracecal ovary Mullerian fusion defects with hemorrhagic ovarian cyst excision with agenesis of right kidney. She was advised regular follow-ups and discussed failure of conception and other issues with her parents. So histopathology as expected was hemorrhagic corpus luteal cyst. So basically while studying anatomy, we had embryology and genetics as a little bit volatile part. I will summarize it in shortly that ovarian descent usually occurs by gubernaculum in the 3rd month of fetal life. Lack of caudal descent or retarded growth of urogenital ridge leads to these anomalies. Lot of syndromes are there like MRKH syndrome where there is uterine and upper vaginal anomaly. In our case, there was no vaginal anomaly. Then along with renal agenesis, there is failure of ureteric bud and metanephric mesenchyme, and these renal agenesis had got multiple associations. There are hundreds of genetic conditions in the literature. We will not go in detail. Diagnostic for these cases rather than CT, because lot of cases are missed of ectopic ovary. So what literature says, diagnostic is 3D ultrasound mixed with MRI used with stimulation of clomiphene citrate. About unicornuate uterus, prevalence of congenital uterine or Mullerian anomalies are around 3 to 5%, and unicornuate uterus is around 0.3%. Failure of one of the Mullerian duct leads to development of this anomaly, and parents should be counseled regarding future miscarriage, ectopic pregnancies, abnormal fetal presentations, growth retardation and premature labor to such patients. Coming towards undescended is the more appropriate terminology which should be used for this type of ovary. And in undescended ovary, absent uterus is seen in around 20% of the cases, and unicornuate uterus is seen in 40% of the cases. They can be in the line from descent, like from liver to the line of descent toward pelvis. There are some classification described by Lankman, like post-surgical implant, post-inflammatory, and like this case, true embryology. They can be unilateral, bilateral, associated, may be associated with urinary tract anomalies, ectopic, genetic kidneys or horseshoe kidneys, then double renal pelvis. To define undescended ovary, they should be, upper pole should be above the level of common iliac vessels. And you can get sometimes multiple tiny cysts behind the colon, and many times these cases go unnoticed because of proper diagnosis. About renal agenesis, it is seen in 1 in 450 to 1000 births. Genital anomalies associated is most commonly seen in females. Associated cardiovascular, GI and skeletal anomalies are seen in around 25% of the patient. Regarding solitary kidney, they should be aware about pyelonephritis, obstruction and calculus in the future. It is a urogenital ridge defect, and like MURCS association, Mullerian, renal and cervical somatic dysplasia, should be cautious about these syndromes. So, in short, I will summarize in my case what I learned. Whenever you are seeing a young female, 1/3 of renal agenesis patients have associated genital anomalies. Physicians should be alert for associated defects. Radiologists should be meticulous during reporting of urogenital anomalies, because most of the time we detect easily non-development of kidney, but we don't look for genital anomalies. And cytogenetic studies are suggested in some cases where multiple symptoms are seen, and along with precautions for solitary kidney, we should educate the parents regarding fertility issues. Thank you. Left kidney. Solitary left kidney was there.
Cornu, the
Cornu
uterine
was on right side.
That was patent.
And the left adnexa was well developed. So it is like that only. Which kidney, the side on which kidney is absent, usually that side uterus is unicornuate. Means there is only horn and no development of further structures like ovary, tubes. They are
Tube
usually
is not
seen
there.
on that side.
Tube is not there on right side.
Tube was not there on right side.
Okay. So left side there was a tube, there was an ovary. So she has got 50%
Yeah.
chances.
Rahul, preserving that right ovary, which is a diseased one, already, and there is possibility of endometriosis also developing in that.
Yeah.
So, if we weigh the risk, future risk of redeveloping the cyst, was it not wise to remove that ovary? Because the hormonal purpose can be served by the left ovary.
Yes, I discussed this case interoperatively with Dr. Fidvi, he is senior gynecologist of the city, and he was of the opinion that looking at the young girl, and there may be possibility that left ovary, although it is seen, may not be functioning for follicles. So presently you can always preserve the ovary. So that was also question interoperability in my mind. So that's why interoperatively I have to call radiologist also and gynecologist also, whether I should remove or preserve. And
Because
are there any chances of malignancy like we see in testes? Undescended and ectopic testes, we usually keep watch for development of testicular tumors. So that was also question in my mind. But he said as much as possible, young patient before conception you should preserve.
You will have to keep her for constant follow-up, because redevelopment of cysts in that area is
possible.
Big possibility.
Yeah.
Any comment on right-sided ovary producing an ovum going through the left tube to the uterus?
Yes, sir.
What are the possibilities?
It is written in the literature that there is possibility, if it is sole functioning ovary, it may still pass the ovum in the peritoneum, and peritoneum from peritoneum fallopian tube may catch that ovum and she may have conception. So that is one of the answer of such question, that if it is solitary you should preserve, that this thing can happen.
Any further question? Thank you, Rahul.
Thank you, sir.
We move on to next case. Forgotten biliary stent, to be presented by Dr. Ankit.
Good evening, everyone. So, Dr. Ankit Jain has recently joined the MIDAS team, and Ankit is a very intelligent gastroenterologist. He has done his DNB from KMC, in Mangalore. So he's joined with us. He's spending 1 year with us to learn, get further, learn further in gastroenterology before he goes back to Aurangabad. So welcome, Ankit, and he'll talk about a very interesting case that we encountered. Yeah.
Thank you, sir, for that kind introduction. Good evening, everyone. This is the case about a patient who had forgotten about his stent, and which has turned out to be a misfortune for him and also a headache for many. Okay, so a 52-year-old gentleman hailing from Nagpur who is a hypertensive. History dates back to 2017 when he presented with abdominal pain which was in the right upper quadrant. That time he was diagnosed with cholelithiasis with choledocholithiasis, and for this he underwent ERCP with CBD clearance and 2 plastic stents were placed. This all happened in outside hospital in 2017. During the same hospitalization, he was advised about the need for the surgery, but he was lost for follow-up. So he remained asymptomatic for next 5 years or so. But in the month of May 2023, he developed cholangitis in the form of abdominal pain, fever, jaundice. For this, he underwent ERCP with which showed a small choledochoduodenal fistula at D1 with blocked CBD till hilum and with multiple broken stent fragments. And therapeutic ERCP was done with 7 French plastic stent was placed during this hospitalization. Again, this was done at elsewhere. In the month of June, very next month, he had again a very severe abdominal pain episode. This time he had a complicated cholecystitis with ruptured gallbladder, landed up in sepsis with EKI requiring hemodialysis. For this, he underwent emergency laparoscopic subtotal cholecystectomy. Post-procedure had biliary leak and fistula, which was draining around 500 ml of bile every day through the drain. And during this, so for this, he underwent ERCP, which revealed a bile leak with multiple broken fragments in situ, which could not be removed with multiple manuals. And again, along with the 7th French stent, a 10th French stent was placed in view of bile leak. And this was all happened till 10th of July 2023 and was referred to our institute for further management. So he got admitted and he was taken up for ERCP with cholangioscopy on last year. I would just like to initially he underwent upper GI-scopy with forward view scope. 2 previously placed stents were visible, which were removed, and the area in the first part of duodenum along with ampulla, that was all edematous, that area. And there was also a choledochoduodenal fistula, which this all area was quite inflamed, edematous with few ulcers. So for this, side view duodenoscope was used, and which was very difficult to cannulate this area. So you can see here. You can see here quite edematous area along in the D1, D2 area with probable papilla which was accessed with the forward viewing endoscope because ERCP scope, duodenoscope could not give a proper angulation, which was a difficult angulation for the. Then with the forward viewing therapeutic endoscope, it, with the help of CRE balloon, it was dilated to around 10 millimeter, and with the help of rat tooth forceps, multiple stents fragments were removed. So you can see in this picture, this fluoro is showing multiple stent fragments. Along with the cholangiogram showing a small leak at this area, and since it was quite a long procedure, around 2 to 3 hours were required after doing all removing of with the forceps multiple fragments and dilating the doing the sphincteroplasty. It was decided to do a cholangioscopy. And he underwent cholangioscopy in the same setting, but again it was difficult since it was a very difficult angulation, and with the use of spy snare and spy bite, fragments were tried to be removed, which was difficult. I'll just play this video showing cholangioscopic manuals to remove the fragments. So here you can see spy snare was used to retrieve the fragment, but it was difficult to I would like to call sir on stage to just.
No, thank you. No, I think so. This patient actually much easier said than done. The axis was almost at 6 o'clock in duodenal bulb D1 with complete edema and swelling. So we even entering the bile duct was very, very challenging. So we managed somehow to get inside, and just to show the previous images. So it's a looped scope position. Getting inside the bile duct was challenging. We somehow still managed to get a pediatric scope inside, and did some direct cholangioscopy with pediatric scope. Some fragments were removed, but going up inside till the hilum was not possible. So we said, okay, now we'll try cholangioscopy. So then we did cholangioscopy. Some fragments were removed, but again, scope kept falling. It was very hard. So I think following this, I think you can. I'll let Ankit continue, and then maybe I'll join in after. Yeah.
Since the procedure was there, being done for more than 2 to 3 hours, it was decided to abandon on that day with the nasobiliary drainage, and it was next day the procedure was again taken, where you can with the use of forward viewing scope, it was again the area was quite edematous, and a balloon dilatation was done of this sphincter, and then in order to take care of the choledochoduodenal fistula and the leak of that, it was decided to place a 6 centimeter fully covered self-expanding metal stent, and where you can see it was deployed into common bile duct. And later on, you can see here, there was quite a bile leak, but these are the fluoro images after the placement of the stent. Then patient was doing well for next 2 to 3 months, but the fragments you could see still they were in the hepatic, and few were there in common bile duct as well, which were quite difficult to be retrieved with multiple manuals. So in the month of November, it was again decided to take him for again one more attempt of ERCP. But as I said, it was a difficult procedure as such because of the area and also multiple issues. Uh, Again, two attempts were failed in spite of using multiple spyglass cholangioscopy and direct pediatric endoscopy. And there was a fractured migrated stent in hilum which could not be removed because of its perpendicular orientation at hilum. This fragment was really difficult as it was perpendicularly oriented at hilum. So just to tell you in timeline what all happened with the patient since 2027. So in the 2027, he had cholelithiasis with CBD calculus, underwent ERCP with stenting, was lost for follow-up for almost 5 years, had cholangitis with choledochoduodenal fistula with multiple migrated stent fragments. For this, underwent ERCP with stenting. In the month of June, he had ruptured gallbladder, sepsis, AKI, underwent subtotal cholecystectomy. He required a renal replacement therapy for AKI, and there was again post maybe a surgical. After the surgery, he had a bile leak. For this, it was addressed by fully covered self-expanding metal stent. In the upcoming, he had a mid CBD leak with multiple stents, fragments. For this, underwent cholangioscopy and fully covered SEMS was placed. In the month of November, multiple ARCP cholangioscopy attempts were done to remove fragmented stents, which all were so far futile or failed. So presently, we admitted him. He was electively hospitalized for surgical intervention with CBD exploration and removal of fractured stent versus further any other interventions offered to him. That during that admission, investigations were hemogram was normal, RFT, renal function test, liver function test, and electrolytes were normal, and USG abdomen showed decompressed IHBR with pneumobilia. So, I would like to call Tome sir to just enlighten further about the case.
Ankit has given us a very good timeline. I was called upon by Dr. Mukhewar sir what we can do for those stent fragments remaining within the biliary system. So with that, we thought possibly it will be a simple affair for us to go ahead and remove those stents surgically, but that wasn't so. So we did a laparotomy via right subcostal incision, and to our knowledge, the whole right upper quadrant was thickly frozen, and that was expected because this patient had bile leak. So we could do the adhesiolysis, do a residual cholecystectomy. There was almost 30% of gallbladder was there still. Did a cholangiogram after removal of gallbladder, and we found that the stent fragments are within the intrahepatic biliary system. We did a supraduodenal choledochotomy, which is a standard. This was all very difficult because of thickened tissues and decompressed bile ducts because of previous stents. The metal stent was still there within the lumen of bile duct. And through that, with available surgical instrument, there are Randall forceps, which we as a surgeons have, which we put in through, and we can go up to the right duct and left duct. But beyond that, we couldn't. So whatever fragments were there in right and left duct, those were taken out. But then cholangiogram revealed that the fragments are still there beyond the primary and secondary confluence as well. So that was the time I thought, otherwise the biliary system was completely normal, there is no disease as such. So I called upon Dr. Saurabh inside the OT and we did a cholangioscopy. Yeah, please.
Yeah. Right, so I think just to recap, this patient, lot of issues, lot of surgeries, leaks. We had put up metal stent with the idea that maybe it will help us go into the hilum, but that metal stent also impinging on the other walls, so there was no way with even the metal stent to go into the hilum from standard maneuvers. And that's why we requested Tomei sir to see. I said, this is really the last resort because, I mean, it is absolutely not possible. As is with cholangioscopy, till hilum is okay. Above the hilum can get challenging for fragmented stents. So with difficult position, we could not even reach the scope till hilum, quite frankly. So that's why, so this, as sir said, multiple small pieces were removed, and these are the instruments advanced. And you can see on the left on the X-ray, yeah, I think, thank you. So on the X-ray, you can see this is the metal stent which was endoscopically placed, and these are the fragments up here. In fact, this is not even doing justice to the actual number of fragments this patient had. It's not even showing some of those. And this is a cholangiogram. And then what we did is an intraoperative cholangioscopy, which is the first one for me to perform. And that's with Tomei sir, me and Bhushan. I think Bhushan is here or having drinks outside. Okay. Yeah. So me and Bhushan were here together doing the case with Tomei sir, and it happens to be my Facebook profile picture also now. So, because I don't usually do cholangioscopy inside the operation theaters. And so this is, the cholangioscope being advanced from the common hepatic duct inside the bile duct. And it all sounds very straightforward, but you realize that when we are actually doing it, we are going about 10 centimeters deep from the skin. Somehow, Tomei sir was guiding me and getting the scope somehow maneuvered inside the bile duct. And this is a video because this wasn't the OT, the recording system was not in place. This was shot on the iPhone. And what you can see are all these little fragments here inside the second degree radicals, and what we are using are our standard equipments with the cholangioscope. As you can see, somehow we're getting the snaring that fragment and slowly pulling it out. I'm just going to change the display settings, I think, 1 second. Yeah. Sorry, I'll just do it again. Yeah. So, yeah, you can almost see in this background us standing on the reflection, removing these fragments one by one. So it almost spent about 2.5 to 3 hours doing this because it was so difficult to get that angle and get inside, and it's a whole maze when you start going inside these areas. Somehow manage with all our angles and fluoroscopy and X-ray to reach different areas, use small tools. There's a lot of inflammation from the manipulation, but no disease actually as such. And this is our intraoperative cholangioscopy of the deep inside the bile ducts that we are performing to remove these fragments. And so despite all that, to our disappointment, we still had this here remaining. Now, after all this effort of 2 hours, now we are looking at 1 and 2 fragment. So what we said was, okay, now we started targeting the left one. I said, listen, that scope is not going to reach inside. So what we did was we said, why don't we go back to our standard basic stuff? We got a guide wire in there, and then with our hands put a balloon, which we normally use for removing stones from the bile duct, and got it quite deep inside that radical, and then pulled one fragment entirely out, which was great. And the more the years go by, the smaller the fragments become, and the more difficult it gets to remove. Now, this is a 7-year-old stent inside. So it is an extremely painful task. So somehow we cleared it, and then we are left with this one fragment here, which unfortunately, despite our all efforts, now we started with cholangioscopy, and you can see the sharp angle. When you go deep inside the radicals, it was almost like a 130-degree angle to put a cholangioscope in. We could barely see it, leave aside taking it out. So that was with cholangioscopy. Again, we standard maneuvers with the guide wire and trying to put our balloon. Because of that 130-degree angle, no accessory could even go inside. So then I think after like 3 hours, you were like, this enough is enough. I think this is 1 centimeter fragment left inside some radical of the bile duct, and hopefully it doesn't cause any problem. So we decided to just let go and come out as this was what could have been done. I think, yeah. So I think Tomei sir can take over, and then Ankit after that.
So nearly all fragments were removed, but one remained. And we did a T-tube choledocostomy. That is the standard procedure. We closed the common bile duct around the T-tube. The metal stent was still in situ. Let me tell you one thing. This metal stent was deep stuck, and I couldn't remove it from the supraduodenal choledochal site. So that was one surprise finding. We closed the common bile duct around the T-tube, did a cholangiogram which was satisfactory. And then you can.
Yes. Thank you, sir. Then his misfortune continued, where post-operatively had fever with wound infection. After clamping the T-tube, had some biliary ooze and staining in right side of wound, which was increasing. A T-tube cholangiogram showed leak from proximal CBD. For this, he underwent ERCP, wherein earlier metal stent was removed, and 3 plastic stents were put beyond the leak of T-tube. Gradually, drain reduced and was discharged in stable condition with T-tube and stoma bag. He reviewed after 2 weeks with the drain removed as everything was healed finally. So this was a ERCP which was done. I'll just show. We'll just play the video where we have removed that fully covered stent, and 3 plastic straight stents were placed, bridging the T-tube area along with. You can see that with the help of rat tooth forceps, the stent was removed. So this was the fluoro image of multiple stents which were placed. Again, you can see that one fragment of stent which was still there. So last follow-up was done 2 weeks ago. He is doing very well. There are no symptoms right now, and we are going to advise him for the stent removal so that history won't repeat after like 2 weeks time. So currently he has been, these are the multiple diagnoses for him. So I would like to just tell you about, these are the recent articles which were published. This was a study done by Sridevi et al. Where they have taken, there was a study done on the patients who had similar, who had forgotten about their stents. So there were total 12 number of patients where median age was around 48, and mean time of presentation was around 31 months, like around almost 2.5 to 3 years, and there was time range of 13 to 96 months. Most common presentation in all of them was cholangitis, like almost 83%. You can see here, ERCP success rate for removal of the stents was around 66.6%, which was successfully removed in 8 patients out of 12. Again, this was about this article. Another article which was published by Dr. Sandeep Shyam Sundar Sharma and Sandeep Nijaman group from SMS Jaipur, where outcome of forbidden biliary stents for more than 5 years. It was a 2-decade experience about the such cases. So it was a total number. It was a retrospective study where 40 patients were included in the study, and most common indication for placing the stent was choledocholithiasis, around 82.5% patients. Of this, most of the patients who had forgotten about their stents, the most common presentation was cholangitis, around 87.5% patients. Few had internal migration, pancreatitis, and 2.5% patients also had portal hypertension. outcomes like most of them were most of them had successful removal with ERCP and endoscopic intervention. Around 5% patients required surgical intervention in such patients. One surprising fact was in this study, 70% patients were aware about the stent placement in them, but 30% were not aware that some stent was placed in these patients. So I would just like to give a take-home message, like proper counseling and instructions by treating doctor to be reminding about the patient about the placement of stents. Short message, mobile reminders, phone calls can also help about this. Stent registry in the department to improve the patient's adherence and to prevent further complications. And also, as we have seen in this patient, intraoperative use of cholangioscopy as and when appropriate and needed can also help. Thank you, everyone.
Hello.
Professor.
One question, Dr. Sudhir. Hello, here. I want to ask one question to you. The story started in 2017, and there were multiple stained pieces inside the CBD. Why not remove gallbladder, cystic duct, as well as common bile duct, and direct to do hepatojejunostomy? That was one of the very good option, I feel.
Initially, we thought so, that could we do, but those fragments were easily coming out, except the last one. And as such,
they require, say, about 6-7 years.
Yeah.
This story started in 2017.
But this MIDAS was involved in story after 23.
It was in the year of...
This all six, initial 6 years were at different hospitals, not in MIDAS.
Yes. Yeah, actually, the patient was seen basically for fragmented stent removal. So really, we did like 1 ERCP or maybe one more attempt, that's it. We didn't do like 6 ERCPs. We did 1 ERCP, which was the first one, where we tried our best, did cholangioscopy, pediatric cholangioscopy, put a metal stent for bile leak and left it. I got him back in November. I said, I'll give you one shot. The idea was that I have a metal stent in there. Maybe that stent will allow me to go deeper with my scopes inside, because now it's a big 1 centimeter hole. But unfortunately, that was not the case, and the stent was impinging on the opposite wall, so my scope could not enter. So then I said, you know what, there's no point. I mean, this requires surgery. So I said, let's just go ahead with surgery. So and from our standpoint, we did 1 attempt. Second was like a last bit effort. So, and then sir was involved immediately after. Yeah.
Dr. Sudhir. At the last...
Why not do hepatojejunostomy instead of...
Because the biliary system was completely decompressed and right upper quadrant completely frozen.
Yeah,
and
Tommy
we
sir,
thought
about...
doing a hepaticojejunostomy for such small fragments is not a good idea. Maybe cholangioscopy is available. Intraoperative cholangioscopy was done for the first time by Saurabh even. And we thought maybe via doing cholangioscopy, we would remove all the fragments. And nearly we removed 99%. Only 1 fragment remained. And finally, we have preserved his native biliary anatomy even today, instead of connecting it with biliary, any jejunal loops or anything.
Praveen, it is easy to say it afterwards, but when you do it in a prospective manner, you always feel that you are able to do with the minor things, so why not go with the minor things? So when the difficulty arises, then you go further. And doing an hepaticojejunostomy for a fractured stent would be too big a surgery, So because we had difficulty, then it's a good thought subsequently that why this should not have been done. But the entire repeated episodes of cholangitis, adhesions, and doing an hepaticojejunostomy in such a setting would also be not without complications.
In fact, look at this T-tube choledocostomy which we did. It was all unhealthy bile duct. In fact, we put in a T-tube and that also leaked. Just after clamping T-tube, it also leaked from somewhere. So it was a very diseased area.
Yeah, I think it may not have been, if that all the edema and inflammation in the bile ducts there from all that, prior stenting, this, that. I think may have been a hard problem with hepatico-J would have leaked also. I think this maybe was the best option at the end.
And bile ducts were not dilated. All collapsed because of the stent, metal stent for last 3 months in situ.
Yeah.
The title of this case was given very well, headache for all. Another title which comes to my mind is, and which I read in one of the papers is, normally we say ignorance is the bliss. Yes. But this is one condition where ignorance is not bliss. So one paper titled was Ignorance is not bliss. Forgotten biliary stents.
Yes. No, and I think this particular, I'll share my, since I've done at least 2-3 workshops nationally for demonstrating cholangioscopy. Usually cholangioscopy is meant for stones and biopsies. So if I've done about 12 cases in different centers in the country, 8 have been for migrated, forgotten stents. That was a surprise to me. I said, what is the list of scopes that I have to do? For 5 cases, usme se 4 are migrated stents. So I think this, and especially government hospitals, I think it's a recurrent problem. Patients are uneducated, they don't understand. And I think what has happened with COVID also is that people got ERCPs, then COVID came, then they forgot, then they have to come back for ERCP. So after 3 years, they come back, and now it's like a bad, fragmented, migrated stent. So that's a new epidemic of sorts happening across.
Our patients tend to forget, that's true. But possibly the suggestion as he gave, maintaining a registry by a gastroenterology department or an endoscopy unit is extremely important. And giving repeated calls, SMSs, registration, calling them, and not ourselves forgetting that I have put in a stent in somebody. It's actually really very, very headache, too much of pain and expenditure for the patient.
I always make it a point that during rounds, I always ask the patient for removal of stent after 2 weeks, 3 months or 2 months, whatever. But Dr. Ankit has suggested that you should have a registry and ask the receptionist to call is a good idea. That would be adding to our armamentarium.
That's right. That's right.
Thank you.
Okay, thank you everyone for attending the 116th now MIDAS clinical meeting. So thank you, Sir Bhushan, Rahul Sir, and Ankit for presenting the cases very well. Thank you, chairpersons, for sparing your valuable time. Dr. Paran Sir, Dr. Kaniya Chandak Sir, Dr. Ritvik Lohia, and Dr. Abhay Sinha Sir. Thank you. And I would like to thank the online chairpersons, Dr. Arun Iyer and Dr. Ankit Dalal. I mean, it's very nice that you could join in, and unfortunately, we're not able to have drinks and food with you. but hopefully soon, yes. And thank you, Dr. Kailash Mishra, as well, if you're there. Thank you.
Can we have their final word if they have?
Oh, yes, sorry. I apologize. Actually, we missed that. Ankit, any comments? I don't know if Arun is also here, but Ankit, we would love to hear from you.
No, it was a wonderful evening. I think great cases, learning points in each one of them. I must congratulate on how you managed all of them really well. Even this last case, it's a nightmare when you have small fragments stuck inside the bile duct. It's a nightmare to get them out. With all the equipment that we have, despite all of that, these small fragments can be a challenge. And I think you did a fantastic job. And I'd like to congratulate you for this wonderful event, and also on your new ESWL machine. I think that's great that Central India has one to treat patients of chronic pancreatitis. Thank you for having me, and hopefully we'll catch up soon. Thanks.
Yes, thank you. Thank you, Ankit. And thank you, the audience, to stay up till 11:30 p.m. here. So thank you for being here. Please join us for drinks and dinner. And last but not the least, thank you, Abbott team, for constantly supporting our educational initiative for so many years now. And you're sincere, you're always there for us. So thank you so much for that. Okay, all of you, please, we can join for drinks and dinner. Thank you. ॲक्च्युली सगळं आपलं सर्जरी असल्यामुळे असे व्हिडिओज नव्हते लाईव्ह असल्यामुळे
झालं ते कळलं लोकांना.
पण ते आता काय करणार
एवढी लंबी लिस्ट आहे इंटरव्ह्यू.
कोलेजिस्कोप कसं काय केलं? When your sidewing scope was not going in, you
They don't forget regarding stent. They don't forget. They fear of new cost.
That's another.
They will cost. मालूम रहता है करके पर पहला अगर का एपिसोड आया तो उनको पहले की जाने की ये ऑपरेशन के बाद हुआ है हाँ यहाँ पता रहता कि हाँ अभी इसके बाद उसके कारण हुआ इसमें क्या है इसमें क्या है कोलेंजाइटिस हुआ उसको